Welcome back to the Health 3.0 podcast, where the innovators shaping the future of healthcare share insights that you need to optimize your health today. I'm Dr. Doug Lucas, the VP of Health and Hormone Optimization at LifeMD. And today I want to talk about one of the foundational areas in Health 3.0, which is hormone optimization. So, for these foundational episodes, I want to start with hormones because, unlike some of the other episodes that we'll do, we'll talk about things like lifestyle and nutrition and exercise and sleep and all these foundational things. But one of the things that's unique about hormones in particular is that the strategy is not clear. What I mean by that is when it comes to exercise, nobody's arguing whether or not exercise is good for you. Nobody's arguing whether or not we should be sleeping or not sleeping. But when it comes to hormones, this foundational tool, there is a clear discrepancy in the strategy. The tactics around the others are uncertain, sure, but the strategy is clear. But here in hormones, the strategy is uncertain. There is so much confusion. There's so much back and forth. Use it, don't use it. It's dangerous. You're going to get cancer. You have to use it. You're going to lose your brain if you don't. Everybody in this space, including providers, doctors, nurse practitioners, PAs, consumers, patients, and everyone is confused because, again, there's so much information and nobody knows who to trust, where to turn. So, what I want to do today is talk about what I've learned over the last 10 years, learning about hormones, applying them to a clinical practice, really through the lens of longevity, through the lens of bone health, and underlining some of the areas of controversy. I want to explain what's happened over the last 20 plus years, where we went from the majority of people eligible to use hormones using hormones to almost nobody who is eligible to use hormones using hormones, and where we are today, which is, I hope, a new era of hormone use when it comes to health span, longevity, and health optimization. That's a big part of Health 3.0, which is education, providing you with the autonomy to do what you think is right for your own health and shared decision making. Because ultimately, you have to be your own advocate, and we are here to help guide you along your way. Welcome to Health 3.0. I'm Dr. Doug Lucas, and I've spent my career working inside a healthcare system that too often waits until you're sick before it pays attention. We're moving past that. We're ready for a new system. We need Health 3.0. This show is for men and women in their 30s, 40s, and 50s who are starting to feel those midlife shifts, that fatigue that creeps in, the weight that's harder to manage. This show is for people who want to take control of their health now. Each week, I'm either going to bring you a solo episode where I break down the latest in prevention and performance, or a conversation with a guest, an expert who is shaping what it means to live longer, stronger, and healthier. So if you're ready to move past sick care, if you want to know what Health 3.0 looks like in your own life, you're in the right place. So the big question when it comes to hormones is how did we become so afraid of using these molecules that our bodies make naturally? Why are we so afraid of these as a profession and as a consumer, as a patient? Ultimately, this fear over the last several decades has changed the lives of millions of men and women who are struggling unnecessarily because they don't have the tools that they need to optimize their health span. I'm going to talk about both men and women in this episode, but I'll spend the majority of the time on women because if the strategy is unclear around men, and that's true, you'll see that when we start talking about whether or not to use it, not use it, the risks, the benefits, especially when we get to testosterone for women, there is so much confusion around what to do, what the research shows, what providers are actually doing, and what people really need, what women really need, and what women really want, according to what they're telling us. So, we're going to spend most of our time on women. We are going to talk about men at the end, and ultimately, we'll provide you with a path forward as we get to the end of this episode. All right, so let's start with the benefits of hormone replacement therapy as it pertains to women post menopause and also to some extent perimenopause, although we're not going to talk about that specifically exclusively today. But some of these things do also work in that phase of life. And then really this also applies to some extent to women who are still cycling regularly, premenopausal women, but really we're going to focus on the postmenopause state. So the benefits here for women are the things that you hear about a lot. Hormone replacement therapy is indicated for, and in my opinion, is the best treatment for the usual symptoms of menopause. So these would be the vasomotor symptoms, right? So this is hot flashes, night sweats, GSM, which is the genitourinary syndrome of menopause, GSM. So that's vaginal dryness, itchiness, atrophy, painful intercourse, chronic UTI, all of these things that go under the umbrella of GSM HRT is indicated for and the best treatment for those things, but it does a lot more than that too. And over the last couple of decades, there have been multiple studies that have continued to show the benefits for bone health, the benefits for mood, the benefits for sleep outside of just resolving night sweats, the benefits for energy, the benefits for body composition, metabolic health, brain health, and on and on and on. And I want to actually double click on the bone health comment that I made there as well, because when it comes to bone health, I've looked at the numbers on this a lot, and I think this is talked about, but not talked about in relation to how significant it is. We'll talk about cancer later when we start talking about risk. We'll talk about breast cancer, other cancers associated with HRT, maybe incorrectly. We'll see. But when we talk about actually dying from one of these things, I want to underscore how important it is to understand that hip fractures have a higher 12-month mortality, meaning dying within 12 months, than all of the leading reproductive cancers stacked together. So that's breast cancer, ovarian cancer, uterine cancer, cervical cancer, and I added thyroid cancer just to get 5 in there. But mortality, death from hip fracture within 12 months is more than all of those cancers together. That's how important it is to understand that we need to prevent bone loss, and hormone replacement therapy, estradiol in particular, is FDA approved to prevent bone loss, but you have to know that you have it. So with all that potential benefit, you would think that the majority of women who can use HRT are using HRT, but that is so far from the truth. Because actually, according to the Menopause Society, somewhere between 4 and 7% of women eligible for using hormone replacement therapy are actually on HRT. And to me, this is mind blowing because there's so much benefit. And what it shows, if you compare this to even a couple of decades ago, go back into the 90s, where around 30% of women who were eligible for HRT were using HRT. What it shows is that we have had a dramatic shift, and in my opinion, the wrong direction, where now so many women are not using it who could. And the primary reason is fear. Now, there's also an access thing, and I think that was probably more true in the 90s. But now with telehealth coverage that should apply to all women in the country, we should be resolving the access issue. So then the primary issue is fear. So why are women afraid? Why are providers afraid? The fear really stems back to the early 2000s. Many of you have probably heard of the study called the Women's Health Initiative. I'm not going to go into all the details. I could talk about it forever. But in 2002, a really unique thing happened. So in the early 2000s, the Women's Health Initiative was a very large scale study designed to look at the potential risks and potential benefits of hormone replacement therapy. They were looking at 2 particular hormones. We'll talk about what they studied and whether or not it was protective of cardiovascular disease. That was the intent of the study. And then they were tracking all these other things, including things like breast cancer, hip fracture, other cancers. And they stopped the study early, and a really interesting thing happened. On July 9th, 2002, the NIH held a press conference saying that they stopped this study prematurely because there were concerns around the risks of hormone replacement therapy. This was before the publication had been released. Now, JAMA, the Journal of the American Medical Association, did publish it online at the same time. But you have to remember that back in 2002, it's not like today where we have very easy access to journals. While yes, it was online, this was not how doctors actually viewed publications at that time. I started medical school in 2005, and it was hard to get access to articles online at that time. You had to be part of an institution, you had to have some kind of online access, and even then it was rudimentary at best. So what happened is the NIH held this press conference, explained the results the way that they wanted to, and then doctors didn't have an opportunity to actually look at the data themselves. So they had to trust what was being put out there. And it wasn't until the 17th of that month, almost 2 weeks later, over 2 weeks later, where the publication actually came out. And then doctors could read it if they wanted to. But by that time, the damage was already done. So what happened? Well, they stated the statistics that they had for the publication, which showed that there was a trend toward an increase in diagnosis of invasive breast cancer and other concerning things too, like coronary heart disease, pulmonary embolism, and stroke. So clearly, yes, these are real concerns. So then what were the actual risks? Well, if you had the publication and you could look at it, you would see that these are considered to be rare, meaning for specifically the invasive breast cancer, for example, there were 8 cases increased in the intervention group per 10,000 patient years. And that's just a statistical way of looking at objectively what is the impact? How many patient years does this actually impact? 8 per 10,000 would be considered rare or very rare, depending on who you ask. And so while, yes, it existed, it did not meet statistical significance, meaning that we cannot say for certain that this was due to chance or that this was real. It has to be statistically significant to be able to say that. And secondly, clinically, is it really relevant? Now, of course, I don't wish a case of invasive breast cancer on any woman, but there has to be enough of a signal to then offset the potential benefits. And the study did show benefits too. There was a reduction in fracture risk, there was a reduction in colon cancer, and there were other potential benefits. But the takeaway from this NIH press conference was that, oh my gosh, hormones are dangerous. Women should consider this, and doctors should probably consider what they're doing with prescriptions. And the impact was millions of women were stripped off of their hormones, either by themselves, they stopped taking it because this went to the public, or by their providers who probably didn't read because they didn't have access to the numbers and went with the momentum of the time, which was to stop using hormones for postmenopausal women specifically. And then the fallout that occurred over the next several years, I experienced personally. So I started medical school in 2005. So this was 3 years later. And in 2005, my training in my first 2 years, the academic part of medical school in particular, before you start rotations, was, first of all, very limited in hormone training to begin with. But secondly, any conversation around hormones, specifically sex hormones, was tied to these are dangerous, consider alternative treatments. And what's interesting about that is that the WHI actually had multiple publications. They were doing multiple things in the study. And one of the other arms or one of the other groups that they studied were women who were using estrogen only. And I'm going to get into what they studied in just a second. But the estrogen only group, meaning without the combined part, the progestin, the synthetic progesterone part, the estrogen only group actually showed nearly to the same degree a protection from breast cancer. And yet that didn't make headlines. And it certainly didn't change the fear. It didn't change the momentum, which is that HRT is dangerous. We should consider alternatives. And ultimately, women weren't getting the conversation around risks and benefits to begin with. And the other thing I want to say here before we talk about what they used in that study is that the rare events that occurred, if you look at other studies, they were really taken, I think, too far and out of context. Again, not to say that they're not important. Pulmonary embolism, blood clots, heart attacks, breast cancer. I mean, these things are significant. But when you talk about rare potential risks and compare it to other studies that have been published even recently, they treated them differently. So, for example, we'll talk about this study again. This is a study called the Traverse study published in 2023 around testosterone for men. And this study, just in brief, was looking at the idea that testosterone could potentially increase the risk of having a heart attack in men that were at risk who were on testosterone therapy. This is important for testosterone. Again, we'll talk about it later when we talk about men. I bring it up now because one of the things that really stood out to me with this particular publication is that there was a risk that was noted in the data, in the conclusion of things like pulmonary embolism, right? So these things that we see in both groups of both women on HRT with the WHI and now in men in the Traverse trial. But what they said in the conclusion for men is that these rare risks did occur, but the takeaway from the study was that testosterone is safe to use. In fact, we know that this was the takeaway because the FDA, based off of the Traverse trials, actually removed the black box warning around heart disease, heart attack, and testosterone in men following that study. So while 8 out of 10,000 patient years pulmonary embolism for men, 8 out of 10,000 patient years pulmonary embolism for women, oh my gosh, you can't use HRT. For men, don't worry about it. It's fine. This discrepancy between research for women and research for men has stood out over the last several decades when you start studying similar things. And testosterone is a great example for this. Hormones are a great example for this. Somehow the mindset is, well, for women, we have to protect them from the things, whether it be hormones or whatever. For men, we could just educate them to say, look, this is a risk, but you get to choose. That is not how we treat humans. We need to educate both men and women and have shared decision making. Again, this is Health 3.0. For those women who are saying the medical system is misogynistic, I mean, this is great evidence of that, right? But we have to move beyond this. We have to educate both women and men and then let them decide with a shared decision-making model what's right for them. Okay, so let's get into the WHI a little bit, not because I want to dissect it, but because it helps set the stage for understanding how we use hormones today. So the WHI used what was popular at the time, which was an oral hormone replacement therapy. This was a combination of these two brand name drugs called Premarin and Provera. Premarin is conjugated equine estrogen. Provera is medroxyprogesterone acetate, MPA. And so conjugated equine estrogen comes from horse urine that's distilled down, processed, and made into a bunch of different estrogens. Many of them the human body doesn't make endogenously. So this is a synthetic estrogen. And then MPA is a synthetic progesterone. It is not the bioidentical progesterone. It is a synthetic progesterone. And let me just take a second to talk about the terminology here. Micronized progesterone, we'll talk about later, is an available drug. It's an option that we like. And it comes in oral as well as topical, but usually done orally. The progestins are the synthetic versions, and that there's a whole bunch of different forms of that. MPA is the one they used in the WHI, but all of these different progesterone-like molecules are called progestogens, and this gets really confusing. And one of the biggest challenges with hormone replacement therapy research is that oftentimes all of the progestogens are lumped together. And I'm going to show you some examples of why that's a terrible idea when it comes to the research. But with the WHI, they had a synthetic progestin and a synthetic estrogen. And then they had the fallout, right? They found this increased risk potentially of breast cancer, pulmonary embolism, coronary heart disease, et cetera. What we know now that we've looked at multiple studies on the synthetic progesterones, the progestins, is that the progestins may be responsible for all of these findings. Additionally, I'll show you some evidence to support the idea that oral estrogens can increase your risk of some of these risks too, meaning that oral estrogens are associated with an increased risk of blood clot, an increased risk of pulmonary embolism, right? So these things that we were relating to HRT as a bucket, now we can say, well, maybe it was the form of estrogen, maybe it was the type of estrogen, maybe it was the route of estrogen, or maybe it was the type of progestin, the form of progestin, rather than potentially the route, or maybe just because it wasn't bioidentical, it had other features, and we know that that's true. When it comes to the fear from the WHI, I wish what would have happened is not that we stripped HRT off of all women, is that we asked the follow-up question to say, well, why did this happen? Was this because of what they were using? And unfortunately, that's not what happened. But now the data over the last couple of decades, we can answer that question more clearly. And then one more thing that's relevant about the WHI is that the average age of the intervention group, meaning the women that were on HRT, was 63. We'll talk about the different age groups later, but most of you probably know that the recommendation is to start hormone replacement therapy within 10 years of menopause. And yet we have this landmark study where the average age of the intervention group was over 10 years out from menopause. They were also more likely to be smokers, more likely to be obese. You get the picture that this is not the ideal population to study and get all of this information and set these guidelines off of, because this is not the population that we're recommending to start on HRT anyway. And then several publications that followed the WHI were kind of used to reinforce the WHI, but if you look at them a different way, they can actually start to peel apart some of the layers of the onion to get to the kernel of truth, which is how we use HRT today. So there was a huge study called the Million Women Study. Sounds big, right? And the Million Women study also demonstrated that if you looked at combined HRT, and this is all progestogens together, but if you look at combined HRT versus estrogen alone, the risks were substantially higher. So again, the progestins are likely the problem here. Another study that I like to point out is the E3N. This is a French cohort study. This is one of the biggest studies that actually separated progestins from micronized progesterone. And when you did that, you could see that the progestins had a significantly higher risk of all the things we're talking about, and micronized progesterone did not. And now there's multiple studies too looking at transdermal estradiol specifically as an estrogen versus oral. And this is debatable, but it looks like oral does carry an increased risk of things like blood clot, pulmonary embolism, and stroke. Topical estradiol does not. A topical could be through a cream, through a gel, through a patch. If it's coming through your skin and not going through your mouth, there is a different risk profile. Now, that's not to say that estrogen and progesterone are free of risk and free of side effect. Certainly, that's not true. Nothing is free of risk and potential side effect. But every woman, as she goes through perimenopause and menopause, should have a conversation with her care provider about the risks and benefits of HRT. Every woman, if she lives long enough, will go through menopause. So we have to have this conversation. But if the risks are amplified in the mind of the doctor and the patient, and the benefits are understated, then that's not a real conversation. We have to understand what the risks really are, what the side effects could be, how we really want to dose it, and then talk about the potential benefits. And this is also where I will plug again. You have to know your bone density, you have to know your bone quality and your fracture risk to have this conversation. It's one of the biggest factors. So again, I'm going to talk about how we're doing this now, how we're looking about hormones through the lens of Health 3.0 later. But I want to flip the script here and let's talk about testosterone. So this will lead us to men, but I want to talk about testosterone for women first, because this was an area of research that I could not believe my eyes. I could not believe what I was reading when I started digging into it. There is a untold story around testosterone in women. And when I started looking into this, I was reading these older articles and these older, kind of summary statements talking about testosterone. And I really got the sense that doctors over the last several decades sort of forgot that testosterone is important for women. You hear these statements like testosterone is a man's hormone. We talk about estrogen and progesterone for women, and you don't hear about testosterone very often. But when I started looking at the numbers and I'm measuring this in my patients and I'm recognizing, wait a minute, women, even premenopausal women who have quote unquote normal levels of estrogen and progesterone have more testosterone than estrogen at any point in her cycle. So how are we saying that testosterone isn't important? Surely it is. And when you start looking at the research, you start looking at what happens when you withdraw testosterone from women, you see, oh my gosh, we talk about, and we will talk about libido and sexual function for women and testosterone, but actually it's much more than that. Testosterone is important for body composition, metabolic health, bone health, brain health, sleep, energy, vitality. All the things that we talk about with testosterone in men are also true for women. And women, again, have more testosterone than estrogen at any point in her cycle if she has normal or above normal levels of testosterone. Now, I'm just going to say that again because people have debated this with me openly. When you look at the numbers, it doesn't look to be true. So if you look at a lab score, for example, you'll see that testosterone looks like a lower number, but it's because the units are different. When you adjust for units, and this is the difference between picogram per ml and nanogram per deciliter, you have to move the decimal point. When you move the decimal point over for testosterone, you can see that the testosterone number is bigger. Now, I've heard some people say, and some, relatively well-known physicians say women have 10 times as much testosterone. I think that's a little bit of an exaggeration, but I think we can at least say that on average, she will have more testosterone than estrogen, again, almost at any point in her cycle, except for maybe mid-follicular phase where estrogen spikes before ovulation. But there's a lot of testosterone. So this is not just a man's hormone. This is also a prominent hormone for women. Now, what's interesting about testosterone for women that is significantly different than men is where they make it. So while when we talk about men, our testosterone is made in our testes, right? In our sex glands. But in women, it is also made in the ovaries to some extent, but it's mostly made in the adrenal glands. And this is very different. And this is really important when it comes to optimizing health and lifestyle because the adrenal glands are also making your stress hormones. So this is why women can be more symptomatic when stressed for long periods of time because it'll reduce testosterone production out of the adrenal glands in favor of making stress hormones, which are the things that she needs to stay alive. And also, testosterone doesn't drop off in menopause in the same way that estrogen and progesterone do. Both women and men have a more gradual loss of testosterone. For women, though, it actually starts substantially earlier. So women, their testosterone levels start to drop on average in their 20s, and it'll continue to drop through the course of their lifespan and get significantly lower after menopause. But again, there's not a significant drop as they go through menopause. But what's happening with women, just like it is for men, is that the starting point is becoming lower and lower. And I'll talk a little bit about that later. But I think one of the reasons why menopause is becoming a bigger conversation is yes, there is finally a conversation that is public about menopause. And I'm very happy about that. But one of the things that's happening is I think that menopause is different now than it was decades ago, than it was 2 or 3 generations ago. And it's because testosterone can overlap from a symptoms perspective with estrogen and progesterone, meaning that if a woman has adequate testosterone and goes through menopause and estrogen and progesterone drop off, she is still supported by testosterone. If she's testosterone deficient and then starts to go through perimenopause when estrogen and progesterone start fluctuating, she's going to be more symptomatic because all of these areas of coverage of the sex hormones are overlapping. You lose one and then you lose the other, and then those symptoms become more apparent. I can't prove this, but what I hear from women who, remember going through menopause 20 years ago versus what I'm hearing from my patients now, because I have patients in both of those generations, is that the experience seems to be different now. And we're talking about it more, which again is great. And this is where the story gets really interesting. And again, I couldn't believe what I read as I started to dig into this. Testosterone is important for women, right? We've already talked about this. Bone health, muscle mass, metabolic health, brain health, sleep. It does a lot of great things. But it also is tied to libido, sexual function, performance, right? Satisfaction. All these things are true in the literature. What happened with testosterone for women is that it became almost exclusively tied to that thing. It was researched mostly for that thing. And the diagnosis that came out of that research is called HSDD, or at least it used to. HSDD stands for hypoactive sexual desire disorder. And I actually have the definition that I'm going to read so I don't say it wrong. And according to the DSM-4, which is the Diagnostic and Statistical Manual of Mental Disorders, yeah, I said mental disorders, the DSM-4 lists it as persistently or recurrently deficient or absent sexual fantasies and desire for sexual activity. It must cause marked distress or interpersonal difficulty, not better explained by another disorder, medical condition, or medication. So that's the DSM-4 psychiatric diagnosis, HSDD. So now we have a problem because the guidelines, even today, say that testosterone could be used for HSDD, but that means then you have to actually have a conversation with your female patients about sexual function, sexual satisfaction, and libido. And that's not a conversation that many women are having. It's not a conversation that many doctors are bringing up. So now we've tied this very important hormone to this diagnosis that a lot of people don't want to talk about. This is a problem. Now, to be complete, the newer version of the DSM has actually renamed it. So now it's called Female Sexual Interest and Arousal Disorder. And essentially, it's the same thing. I have the definition. I'm not going to read it to you because it's essentially the same thing. It just put a timeline on it of 6 months. So again, we have this now definition. We have this diagnosis that we now need to diagnose a patient with. But in order to do that, we have to ask some relatively uncomfortable questions. Most doctors don't have time to do this. They're not going to do it. And even if they did want to do it, because there are instruments you can use to do it, there's no drug to prescribe. Let me explain what that means. While there are drugs for men, testosterone for men, there are FDA-approved products. There's several of them. There's no FDA-approved testosterone for women. So even if a doctor wanted to prescribe it, even if they went through the effort, had the conversation, agreed on a treatment plan, they can't prescribe a drug that's FDA approved. So now they're kind of stuck in a box. So they do have some options, but many doctors are not comfortable with what I'm about to describe. Because as a doctor who does prescribe testosterone to the best of my ability in the states that I can, I have to make a decision around how I'm going to do this. So I pretty much have two choices. So I can use a compounded product, meaning I'm going outside of the FDA approved products. I'm going through a compounding pharmacy, which opens me up to potential risk of how good is this product? Is it well controlled? Is it going to do what I hope it's going to do? And we can do all kinds of different compounded things. You can do troches, you can do creams, you can do gels, you can do injections. So there's lots of ways to do it, but you have to get comfortable with using compounded pharmacies. The other option is to use a product that's made for men at obviously a lower dose. But this gets challenging because the most common ways to do this for women is to use two topical products. So one is androgel. Androgel comes in a pump. That pump delivers 20 milligrams of testosterone per pump. 20 milligrams is too much for a woman to use, the vast majority of women on a daily basis. So then you're having infrequent dosing that's not particularly physiologic, and you're going to have an up and a down. You can then pump, you can use part of what comes out. That's not very accurate. So we don't like to use the androgel method that way. The other product that creates a topical for men is Testim. Testim comes in a 50 milligram tube. And so that's designed for men to be used all at once. It's disposable. You open it, you squeeze out 50 milligrams, you put it on your body as a man. For women, we want to aim probably for a tenth of that, right? Around 5 milligrams, maybe 10 milligrams. So then your options are to either open the tube, use a tenth of it, and then throw away the rest of it, which is very expensive. Or as a doctor, I'm telling a patient to use something that's designed to be disposable and then using it for several days in a row. That's actually also irresponsible. So we're kind of stuck where we can either use compounding products or we can use products for men at lower doses, but both of those expose me as a doctor to risk and you as a patient to risks that you don't need to be exposed to. And what's super frustrating about this is that the FDA actually has been presented with drugs that have gone through trials that, in my opinion, with what I've seen about them, should have been approved. There was a product that in the early 2000s was studied, took to the FDA. They studied it for HSDD, which they had to because that was the indication, the guidelines. They took it to the FDA and the FDA rejected it because they were concerned about the long-term risks of using testosterone for women. Now, this is interesting because similarly, in men, we have similarly designed studies that the FDA approved. In fact, this is an era where they approved a lot of the stuff that I'm talking about right now. So while, again, for men, it's okay to have these risks, for women, it's not. And specifically, they cited the things that we know are not true. So they cited concerns about cardiovascular risk. I'm going to talk about the Traverse trial again, but definitely not at those doses in women is that a concern. They talked about breast risk, breast cancer specifically. There are some studies that show that maybe testosterone, because of its impact with estrogen, could have a negative impact on the breast, but it's actually protective of breast cancer cells. It makes them die. And the long-term safety piece, again, this is just silly because this is an endogenous hormone. Women make it naturally. We have decades of use in other populations showing safety. So why did the FDA refuse this drug? So fortunately, things are changing anyway. We as physicians who are strongly motivated to provide women access to these hormones are working to find ways around the system that is put in place of us. But I hope you can see that there is a huge gap in care between women and men, which I'm going to talk about in more detail right now. But this gap is not biological. This gap is cultural, this gap is political, and this gap needs to be closed. All right, so let's talk about men. So this won't take nearly as long, I promise. So for men, the strategy is a little bit more clear, but the tactics are kind of not. So for men, testosterone is known to be very important outside of libido, right? We have studies on men that shows, yes, it's important for libido and sexual function and orgasm and satisfaction, and all those things are true. But we also have studies on men specifically looking at symptoms of aging. There's even a whole scale around this, where we know that for men, it's important for muscle mass, it's important for energy, it's important for sleep, it's important for mood, it's important for all the things that we talked about for women. But the challenge for men is the diagnosis. Because again, there's fear around testosterone. We'll talk about why we don't need to consider it to be as dangerous as many do, but there's fear around testosterone. What happens if I do it? That fear is mostly centered around prostate cancer, cardiovascular risk, heart attack, blood clots. I'm going to get into that. But because of this fear, I think the clinical diagnosis that we need to make as a physician to be able to prescribe under the guidelines are pretty darn strict. So we need to actually diagnose a man with what's called hypogonadism, meaning that the testicles are no longer producing enough testosterone. The guidelines clearly state that you need to use this definition, and that definition has very low cutoff criteria for total testosterone, and some of the older criteria use total testosterone alone, which is not a great biomarker. More recent research shows that we need to be looking at other things like free testosterone and symptoms to get a more complete picture of what men are experiencing. So if you go back a couple of decades, it was much harder to get testosterone than it is now because we have great researchers who are doing the studies to show that men can be symptomatic even if their total testosterone is not very low, like under 300. Some guidelines would say under 280. Very, very low to be truly quote unquote hypogonadal. Many men are experiencing symptoms above that, and these are symptoms of low testosterone. And that could be, to go through it, fatigue, could be a depressed mood, could be for some men anxiety, could be reduced libido for sure. We talk about sexual function in this. Difficulty maintaining muscle mass, body composition, sleep apnea, metabolic health, and on and on and on. So some of these symptoms, of course, overlap with other things, and this is the problem. But we need the freedom to be able to diagnose it and to trial testosterone in one way or another. And again, I'll talk about how we do that. But first, let's knock out the fear part. So when it comes to prostate cancer, some newer research is really opening up the opportunity for us to use testosterone in men that have concerns around prostate cancer. In fact, there are some centers who are actually using testosterone in prostate cancer treatment or using testosterone for men that have prostate cancer but are just watching it. So let's talk about why this is true. The original fear was based off of some really not very well done studies showing that testosterone can make prostate cancer cells grow. This is true for sure. But what they were missing in those early studies is that there is a saturation of the testosterone receptors in the prostate. So one researcher in particular, Dr. Morgenthaler, who's done a lot of research in this, demonstrated what's called the saturation model, meaning that at relatively low testosterone levels, under 300 nanograms per deciliter, at relatively low testosterone levels, the prostate becomes saturated, meaning that you can add all the testosterone in the world on top of that, and it's not going to have an impact on your prostate. In addition to that, low testosterone is actually associated with an increased risk of prostate cancer. So now you actually can say, well, if you are at risk of prostate cancer, you should, if you have low testosterone, actually be on testosterone, not avoiding testosterone. It's a different way to look at it. Now, the idea of prostate size in this is a whole nother conversation that I'm not going to get into today. But those that have large prostates, benign prostatic hypertrophy, BPH, there is a conversation to be had here around whether or not replacement is right, what kind of breakdown, metabolism of testosterone into DHT. I'm not going to get into those details today. But from a prostate cancer perspective, I think it's safe to say that low testosterone is a risk factor. Because of the saturation model, adding testosterone on top of that does not increase your risk of prostate cancer. Now, we can back into the cardiovascular risk, the heart attack risk, in a similar way. Low testosterone is a risk factor. Maybe not directly if you think about why, but because low testosterone is associated with poor metabolic health, it's associated with obesity, with diabetes, with sleep apnea. So maybe it's not actually the testosterone, but we know that that state is not good for your heart. But for years, and because there were some, again, not well done studies, for years, we were told that testosterone replacement therapy will increase your risk of heart attack. Fortunately, like I said, the Traverse trial was designed to help to refute that. Now, the trial was not perfect, as most hormone trials are not, but what they did show is that men who are at high risk, who were on testosterone replacement therapy, did not see an increase in events compared to placebo, meaning that the takeaway was testosterone should not increase your risk of cardiovascular event. But like I said before, that study did show an increased risk of pulmonary embolism. Why would that be? So one of the things that testosterone does do in a subgroup of men, around 10 to 20% of men, is to increase the number of red blood cells. Some interesting physiologic reasons why. I happen to be one of those people. But what happens with exogenous, meaning from the outside testosterone in this population, is that the number of red blood cells will go up. So we measure this through hemoglobin and hematocrit. You might have heard this called sticky blood or thick blood. And so for men where this occurs, we have to either watch your dosing and maybe consider a lower dose or undergo phlebotomy, meaning donating blood, which is good for our community anyway. And so for that population, if this is untreated, there probably is a subset where this could potentially be dangerous, although actually the literature doesn't really show it. And one of the things that's frustrating about this is I see men who've actually been taken off therapy because of this, which I think is unnecessary because their hemoglobin and hematocrit will rise, their number of red blood cells will rise, but this is consistent with being a little bit hypoxic. What I mean by that is like living at altitude. I lived in Durango, Colorado for 3 years. So our house was at 7,000 feet. At 7,000 feet, your hemoglobin and hematocrit are going to be higher than people who are at sea level substantially, there is not an increased risk of blood clot for people who live at altitude. So it's not just a subtle increase that's going to do it. And there are things that you can do about it. You just have to watch it. So I think the risk comes in for men who have a significant reaction to it and who aren't being monitored appropriately. And again, it's not that there are no risks. We just have to understand the risks. So that's heart attack, prostate cancer, blood clot. Those are the three that people worry about. Now, there's some side effects. I'm not going to get into those today, but those are the three reasons why people have fear around testosterone therapy. So let's wrap this up. So now that we've gone through the risks, we really only highlighted the benefits, but let's talk about how we're looking at this now. So now in the Health 3.0 model, we want to consider the hormones, estradiol, progesterone, testosterone, as tools in the toolbox. For women as they go through perimenopause and menopause, should we be considering some of these things based off of symptoms, based off of biomarkers? Same thing with men. What are your symptoms? What are your biomarkers? And by biomarkers, I mean blood labs. What are your symptoms? What are your biomarkers? Are you a candidate for a trial of some kind of hormone replacement therapy? And the reason why this is critical is that when we think about this from a longevity perspective, we want to do this through a root cause analysis. Why are we seeing the things that we're seeing? And bone is a great example of that. I say often in longevity conferences when I'm on stage, if you're losing bone, something's wrong. What is it? We need to figure out what it is. For many women, it's loss of estrogen. It's actually true for men too. As you lose testosterone, men don't make estrogen outside of their testosterone conversion, so they lose estrogen and they lose bone. So my mindset around this is, well, if that is the thing that we can identify, which is the biggest root cause, that we should use these tools to help improve that thing. That's actually why it's FDA approved for osteoporosis. So great example, right? Where we could either treat the diagnosis with a drug like a bisphosphonate, like Fosamax, or we could treat the root cause, which is loss of estrogen, with estrogen. And for men, potentially this is testosterone. That's an off-label indication. We know that similar things are true with progesterone. Progesterone has sort of been wrapped around just balancing estrogen, particularly in the uterus for women, but actually it does so much more than that. We know that progesterone has an impact on bones. We know that progesterone has receptors and an impact on brain health. We know that it can help with sleep, no matter how you take it. We know that it has an impact on nerves. Progesterone is a fantastic molecule, and we need to use it as such, not just as a co-captain to estrogen and HRT. And then finally, testosterone for both women and for men can have a powerful impact for those that need it. And we really need to open up the indications to include symptoms, better biomarkers, so that we can treat both women and men who need this really important molecule. And I'll give you my own personal example of this. So as a young 40s man, I was having many of the symptoms of low testosterone. So I was fatigued, and there was a lifestyle component to this for sure, but I was fatigued. I was noticing significant changes in my body composition, despite no changes in my diet, no changes in how I was working out. I was losing muscle mass, right? All of a sudden, I'm gaining fat in my belly, and it didn't used to do that. It used to be different. And so my mood was lower. I was struggling. And when I tested, my total testosterone was quote unquote normal. See this all the time, right? I've seen it in the 400s. I saw it in the 500s. But what my doctors weren't checking is my free testosterone, which was in the single digits. It was actually almost as low as some of my postmenopausal women patients. Nobody was looking at that. So because I have what's called a high SHBG, sex hormone binding globulin, which we need to be checking with your hormones, because I had a high SHBG, my free testosterone was very low. I was absolutely symptomatic, even though I had normal total testosterone. I see this all the time. And so I've been on testosterone therapy for about 4 years now. I plan on being on it for the rest of my life. I control the side effects. I control the symptoms. We look at the dose. Of course, I'm doing this with my physician, and I feel amazing. Great energy, great sleep. I have more muscle mass now than I have at any point in my life. I'm fitter, I'm stronger, and I am showing up for my career, for my mission as a father and as a partner. And testosterone plays a big role in that. So I want more men and I want women who can have a similar experience to be able to perform their best. And optimizing sex hormones is an absolutely large foundational piece of that. So that's it for today. So please remember that in order to age with strength and grace, we need to prioritize our health.